Hi, my name is Mohammad Taha Khan, and I'm one of the trainee gastroenterology registrars in Yorkshire region. The topic of my presentation today is gastroenterology outpatient transformation or clinical assessment service, for which we use the term CAS. In early 2019, we anticipated that there is a massive backlog of patients waiting to be seen in the clinic for the first time. Now, to deal with this backlog, we implemented the system of CAS to uh, address and treat these patients without having the need to see them face to face in a time efficiently and obviously safe manner. GPs use three modes of referral to our specialty. One is an urgent new referral. Second one is routine new referral, and third one is choose and book service, where a patient decides which trust they want to be treated at. To apply the system, we were lucky enough to have an IT system already in place, which was obviously tailored according to our needs by seeking help from the IT department. We appointed a CAS coordinator to address the administrative side of things. Currently, we are running two clinics per week, and in each clinic, we see 20 patients, that is 40 patients in a week. After a consultant has gone through the referral, there are usually five outcomes, which, as you can see in my uh, poster as well. First is an outpatient appointment, which can be new or follow up or telephone appointment. Second one is an appointment after investigations. Third one is investigations requested, and we are waiting, depending on the results, whether to appoint them or to discharge them. Fourth one is an advice to the GP, and the patient is discharged back. And the fifth one is an inappropriate referral, where again the patient is discharged back. You can also see an outcome after follow up appointments on the poster. There are usually three outcomes. First one being a face to face appointment, which can either be a routine or an urgent one. Second one is again advice to GP and the patients are discharged back. And the third one is an inappropriate referral. Before applying the system, we obviously faced challenges, and the most major one was awareness among GP and patients and the department. This was basically dealt with by conducting awareness and teaching seminars in the community, in the hospital, and we obviously sent letters to the patient to make them aware of the system as well. We have been successfully running the service since April 2019, and we audited the service for the first time in December 2019 after 9 months of successful run. I've got some of the key results I wanted to share with you. We dealt with 1,254 patients through CAS Clinic from April 2019 to December 2019. 21.1% patients were discharged after reviewing the referrals with advice to the GP regarding treatment, or some of them were inappropriate referrals. 29.3% were given another appointment. 49.6% were sent direct to investigation before deciding further treatment or their appointments. 1,111 patients were managed without ever having face to face appointment with a doctor, and the non attendance rate fell down to 0%. There were a lot of positive outcomes since we've started using this system. Patients who were seen in clinic face to face had their investigations already done, so this obviously expedited the treatment. With advice to the GP, we have empowered GPs to manage with basic GI problems in the community, hence, we've reduced the burden on our department. As I mentioned earlier, 1,111 patients out of 1,254 patients were managed without ever having face to face appointment. 871 patients were managed without first attendance. 113 follow up appointments were avoided. A total of £117,259 was saved in these 9 months by avoiding all these appointments. The number of non-attendance, as I mentioned earlier, fell to 0%, and I believe the practice dynamics are quite safe because the practice is mainly investigation dependent. The patient's feedback so far is quite positive as well. In future, obviously, we plan to increase the number of clinics we are running per week. The model can be implemented in other specialties, rather all specialties across the trust. In current situation where due to COVID pandemic, the face-to-face clinics are quite limited, this model can be quite successful. We also plan to assess for any negative outcomes in our system and scrutinize them and make the system safer for our patients and doctors. Thank you very much.